Can you hear me? Okay, do I need to hold it like this?
Check 1, 2. Check.
Hi, can everybody hear me? You can? Okay. I'm sorry for the moments of us just getting the mics together. I'm not a tech person, and I don't have any pockets, so that's why I'm carrying this bag to put the lavalier battery in here. So thank you for your patience with that. Well, welcome to the last session of the CEU conference. For those of you who do need CEUs, this is the one that qualifies for for social workers. We have to do the one CEU of suicide prevention and assessment every 2 years. This one will qualify for that. And you'll see it when you do the evaluation in it, and then just obviously keep it with all of your CEU certificates. So we're just going to jump right in. I'm Laura Foster. I'm a clinician with New Vitae Wellness and Recovery. At New Vitae, I specialize in military and veteran behavioral health, and I also have a background in suicidology. Prior to working at New Vitae, I ran a crisis program for Lenape Valley Foundation, and I spent a good portion of my career working with individuals in crisis, be it either suicidal, homicidal, deep psychosis, individuals in the military who I've used to work. I was a civilian contractor for the Department of Defense who are dealing with sexual assault and domestic violence. So this issue is something that's very close to my heart, talking about suicide and seeing how I can always improve my practice, and putting these presentations together always helps me with this. And thankfully with me today, I have my colleague Ezri, who is going to do the presentation with me.
Hello. I'm Ezri Lutz, and I'm also a clinician, a new clinician with New Vitae. Been working with Laura for about a year. And yeah, I'm going to turn it back to you.
Oh, thanks. Okay, so I know that sometimes, and most of us know that for some of us that feel activated at times talking about some of the risk issues that happen with suicide, or about suicide in general, we do have a counselor in the audience. If you just I just want to talk to someone for a second. Brianna over here. Brianna, can you raise your hand? Thanks, Brianna. Is another clinician in our practice. You can talk to her. Also, not for now, but later in the presentation, we're going to be doing something where we're going to ask you to look at the handout that was given to you. So you should all have a handout and a nice pen with you. So real quick, what we're going to be doing is I'm going to be talking about understanding suicide risk, and kind of what the state of suicide is in the U.S., going briefly over assessments. I'm really going to kind of focus on the difference between what a screening is and what an assessment is. And then we're going to do a role play, which is going to talk a little bit more about the space of what it feels like to go through an assessment as a clinician and also as a client. So that's the kind of what do you think part of it through this presentation. So we're going to dive right in and talk about the reality of suicide in America. I think most of us kind of know these statistics by now. The thing about suicide is that it really is a public health issue, right? This is one of the leading causes of death in our society, and it should be treated as such. There needs to be more preventative measures. We're all kind of working, especially those of us that are in practice, to try to bump up our assessment and treatment skills around this. Know that sometimes the numbers can be underreported. There's a research study that was done where they talked to coroners and medical examiners, and they talked about how they report suicide, and there was an acknowledgement that some of them do have a space where they feel that it's underreported unless there's proof positive. If there's a suicide note, they report it, but if not, sometimes they think it might be a suicide but don't report it as a suicide to protect the friends and family. So we can guess that these numbers could be a little bit low. One thing that's not on here is that, one of the things in looking at the statistics, that the person that is most likely to die by suicide are middle-aged white men. Does anybody have a guess why this would be? Why is it white guys, middle-aged white guys that are going to die by suicide? Say that again? Midlife crisis is a big thing, right? Yeah, this kind of what am I doing with my life? Also, men, and especially white men, have carry a lot of firearms, and having guns is the most often way that people die by suicide, and that's a population that does have a lot of guns, and so if that's your method, you are more likely to die than if you choose a different method like strangulation or overdosing. So I want to talk just a moment about like some of the vulnerable populations. Like these are considered risk factors, but it just means that you're higher risk than the general population if you fit into one of these communities. But it's not obviously that everyone in these communities is at higher risk. I want to talk just real quick about the one with neurodivergence, because the statistics, I didn't explain them that well, but the 34% is those who are neurodivergent that experience suicidal ideation, and the 22% are those that have plans. And this was a study that was done across the autistic population and possibly autistic individuals. Another like really important space to look at here is around veterans, and kind of going back to the space around lethal means. So firearms are used in 71% of veteran suicides, and gun suicide is the leading cause of death by suicide in the United States. So we should all know that just owning a firearm, just owning it, puts you at higher risk for dying by suicide. No other risk factors, just having that in your home. So it's not saying anything judgment on having guns or not, it's just some information that you need to bank. And as you're assessing someone, you always need to ask, do you have any guns in your house? It's just like a standard question, you gotta incorporate it into your practice and then start thinking about access to lethal means. There's a really cool training called CALM. It's around like access to lethal means, and it kind of helps the clinician to really have these sometimes difficult conversations with individuals who own guns and are not willing to give them up, but just to help to have that space with it. I also want to kind of focus here on the queer community, just because there's a lot of misconceptions around being a part of this population. Being queer in itself does not put you at higher risk for having higher struggles with mental health issues or being suicidal. It's being queer in an unsupportive environment. So it's not being gay, it's not being trans, it's not any of those things. It's being trans in an unsupportive environment. So does anyone here, I'm sure people have heard people talk about like the gender dysphoria, right? So unfortunately in our culture today, there's this misnomer that anyone that is transgender has gender dysphoria. That is unilaterally not true. Gender dysphoria is a DSM diagnosis, and most of the research supports that those individuals who are transgender that are diagnosed with gender dysphoria experience gender dysphoria because of being in unsupportive environments. So it's not being trans that causes you to have higher rates of suicide, and they bump up way higher than anyone else in the queer community, especially our trans youth. It's because of being in schools that are unsupportive, in home environments that are unsupportive, workplaces, your community that is unsupportive. So that's where we have to be very careful when we're talking to people in those populations. I don't have a slide on this, but I wish I would have put it in here, is that another like high-risk population, something that's rising right now, is African-American children, like African-American adolescents. So their rates of suicide attempts have been rising dramatically over the last 10, 15 years. The suicide rate actually rose 144% from 2007 to 2020 for 10 to 17-year-old individuals who are African American. Can we guess why? It's not for being black. It's for being in an unsupportive environment. It's from being like discrimination. It's for institutional discrimination. It's racism. It's policies that inhibit your ability to be yourself or access care. Like those are the reasons, and this is specifically for children too, so we need to think about what's happening in our schools with it. So, yeah. Thank you. Yeah, it is. It's actually, I don't know if I put it in here, but it is something that I wrote to talk about, and I wrote it as like not on the slide, is bullying. So this is one of the risk factors, is bullying. Right? And like you think about what it feels like. I mean, I think about as an adult at like 50 when someone's like, you're fat or whatever. And I'm like, ew, like it hits you, right? But imagine being little, right? And already having other struggles. And the last slide I did talk a little bit about being like intersectionality, right? So maybe like being black and being a heavy kid and people just like targeting you, or being like one of the very few queer kids in your school, what that feels like, or in your workplace, like what that feels like. So absolutely bullying and online bullying. Also, what's not on the slide is like kind of family discord. These kind of like situational things are things that a lot of people report as kind of like amplifying and activating their suicidal ideations, legal problems. Divorce is a big one. I saw that a lot with the soldiers that I was working with who served. And just like something else real quick in here that I always thought was interesting under the warning signs is improved mood after depression. So I remember when I first learned this, I was like, I feel like if you're depressed, like, right, that's when you're going to be more likely to take your life. But it's not true. It's when you're coming out of a depression, right? And it's kind of moving through it and having energy is the space where people are more likely to take their lives than when they're in the depths of a deep depression. So it's just something to be mindful. Like if you have a patient and they've been depressed forever and they're starting to feel a little bit better, you need to red flag that and just to kind of like keep a check on them and ask them, like sometimes when people are in this space, when they've dealt with like sadness and depression for a long time, that when they start to come out of it, they actually have thoughts of wanting to like harm themselves or kill themselves. Like, are you experiencing that right now? For those of us that are clinicians, most of us probably know this already, but there are some diagnoses that are important for us to understand that can have higher rates of suicidal ideation and attempts and deaths by suicide. So you can see like the first one is like schizophrenia and schizoaffective disorder are the highest risk for death by suicide. And something else interesting for bipolar disorder, just to know that women are more affected than men of dying by suicide if they have a diagnosis of bipolar. And then, of course, substance use disorder. We do find that a lot of people who are under the influence of alcohol and have other struggles, this bumps their risk of attempting to take their lives. So it's something else to kind of consider, too, if someone has a substance use disorder. Also, if anyone has any questions or if I'm going too fast, whatever, just raise your hand and we can slow down here for a second. I love this slide because I feel like it just puts out there the things that, if you're not in this field, you could maybe think, or if you're in this field, you hear this all the time. And I'm sure that all of us at some point have either maybe kind of thought this or like have had like some space with this at some point. I would say that the thing that I most hear is about that talking about suicide is going to make people suicidal. Has anyone heard that before, right? Like, yeah, I mean, I've heard it. Outside of my work at Vitae, I also run a nonprofit to fight for the preservation of public education and to also, to fight against discrimination that happens in schools. So I do a lot of work in the schools. And one of the things that we see a lot now in our school districts in the area that I'm at is trying to cut back SEL. So I don't know if anyone works with children, but SEL is like social emotional learning. This is the place where you're reading a difficult book, most of which schools are very fond of banning, things like Tears of a Tiger, right, that talk about suicide. So social emotional learning has these deep places, but you also are pushing in guidance counselors, and the teachers are trained to talk about these hard issues like mental health, addiction, racism, like genderism, all of these kind of things that happen in real life. Because they're getting pulled out of schools, right? The rationale is that if you talk about this, it's going to make it happen in the schools. It's unilaterally untrue. It's unilaterally untrue. So when anyone talks about banning a book because it talks about depression or racism or queer people, know that that reason that they're giving you, if they're saying it's because it's some contagion factor, is not true. And there's tons of research to support that. I will soapbox on that, so I will, let me go to the next screen. So I want to just take a moment and like see this space of like screening versus assessment. So I don't know about you guys, but I mean, it's been a hot minute since I've been out of grad school. I didn't learn this stuff in grad school. I learned this stuff outside of grad school. Like I learned a lot of it, honestly, like working for the Department of Defense and kind of getting my feet wet and people that are dealing with some really intense situations. Screening is not the same as assessment. And a lot of practices that I have been in do screening, but they don't do assessment. So as practitioners, there is this place where we can do both. And not only can we do both screening and assessment, but you can treat the suicidal patient with plan, with intent in your practice if you are trained in things like CAMS, which is a collaborative approach to managing suicidality. Magellan was here a little bit ago. I don't know if there's anyone from Magellan still here. Probably not. Oh, you're Magellan? Oh, okay. So Magellan just did this whole initiative on trying to get clinicians trained in these outpatient therapeutic evidence-based techniques that you can treat someone who normally we would be like, oh, call crisis. Like, we got to call crisis. We got to send them to the ER. When really, if you have a strong assessment tool and clinicians that are trained in this, you don't need to be sending people to the ER. And having run a crisis department, most often, if they're not meeting that deep criteria, like acts of furtherance, we'll probably be sending them back to you anyway. Well, you're looking at one of them, and Brianna, raise your hand, is another one, two that are going through it right now. It's an incredible, incredible program. Okay, see this lady if you want your practice to get trained in CAMS, because it really is an incredible thing. So most of us in our practices, we will do the CSSR, like the Columbia Suicide Severity Rating Scale, which is good, right? This is a really good thing, and a lot of us use it periodically with clients. You know, you should be doing it at intake or some version of this as a screening tool, right? When someone comes into the practice, you know, evidence-based is do it like once a month with your clients, and then, you know, as a clinician, you can kind of determine what makes sense after that. The Columbia can be used by anyone. You do not need to be a mental health professional. You do need to kind of go through a very brief training, and it is an incredible tool. It's evidence-based. There's been like more than 600 peer-reviewed studies that have been published demonstrating its validity. So it's something that is very useful for us to start to look at, do I need to look at this further? You take something like the Columbia as a screening, and then you go in to the assessments. This is just an example of it, and I'm not going to spend a lot of time on it because each place has their own different way of doing assessments. As long as it's evidence-based, it doesn't matter. But know that it's deep. Know that it's a lot of questions. Know that it is going through all of these things. So this is the one that I was trained in. This is what the Department of Defense has used. So you go through behaviors, emotions, situations, and thoughts, right? Seems pretty, like, basic, but then you get into each one. So there's all of these questions, right? And some of these questions lead into other questions. You know, like if someone was like, they haven't attempted, you don't need to go into past attempts and ask all of these questions. But these are the things that we know, like, through lots of research that shows, like, these are things that are going to help us not only to assess for their level of risk, but then for the next steps. So I'm just going to kind of quickly go through this. The one, I do want to stop at this slide just for a second, because the last one down here, like evaluating emotional pain, like in my work, this is the underlying struggle for most people who have dealt with suicidal ideation and homicidal ideation. There's some psychological pain that they're dealing with. And if anyone's interested, there's an incredible psychologist by the name of Dr. Joyner, Thomas Joyner. He did the interpersonal theory of suicide. And what Joyner talks about are these three components that typically come together for someone to be suicidal. So they are thwarted belongingness, being like, no one here, in a room full of people, I don't belong. I look at all of you and I just feel like I'm not worthy. This is not my place. I don't belong here at all. Burdensomeness is that, like, you having to deal with my crap is now more work for you, and I don't want that. I don't want to be a burden to anyone. And the last one is acquired capacity or capability. So this is being like accustomed to death, right? So for those of us who are clinicians, you fall in this category. If you've ever had a suicidal patient, like, you've talked about death, like you have heard about death, you've read about death. These, like, think of, like, you know, obviously people in the military, you think of nurses, veterinarians actually have very high risk for suicide because of their closeness with their proximity to death too. So, I mean, Joiner's kind of like the foundation for a lot of the other models that developed later on around evidence-based techniques for treating the suicidal patient. So then you just kind of go through the rest of this. I mean, this doesn't really matter so much because this is something you would build in your practice. But the purpose of this is that it typically includes 3 levels. So there's low, and then medium and high are weird to me, but it's like non-imminent and imminent. So imminent is like we need to be doing something right now. But this really is just dependent on the capacity of your practice or your agency to determine these levels of what it needs. Another like really good resource to try to like incorporate into your practice is Zero Suicide. If you just Google it, you will find a website that goes through all of the best practices as an agency that you want to do. So this isn't just around getting your clinicians trained in things like CAMS. It's not just about having screening and assessment. This is also about things like your billing department is trained. Your EHR has flags in it that someone is high risk. Your billing department sees like, oh, red flag, high risk for suicide. I'm not asking them about money right now. I'm not calling them about like missed appointments. I'm letting everything fall, whatever your agency decides. But it's an incredible model. It's one of actually Magellan pulled from Zero Suicide to start the CAMS trainings. So this is just kind of like a high level overview of the difference between screening and assessment. But I'm going to pass to Ezri here now to talk about relational attunement. Oh, I have that written twice. Sorry. Whatever.
Hi. Can everyone hear me? Awesome. So we are talking about relational attunement. There's a few good tips up there. What helps? Validating the difficulty of disclosure, using direct but compassionate language, some things that might hinder assessment, like rushing through assessment items, overreacting or appearing anxious. Some of these might seem kind of obvious. We don't want to rush through assessments. I want to really emphasize these points, though, because these tools are necessary to build a therapeutic relationship with individuals who are already in the most vulnerable place. One of the reasons that I'm here with Laura presenting, I am a new clinician working with Laura. I'm also a clinician with lived experience. I've been on both sides of assessment. Over 20 years ago, when I was a teenager, I experienced when some of these tools were not used. I can remember meeting with a therapist who was assessing for suicide, and they used jargon, confusing language that I didn't understand. And I felt dumb for not knowing what they were talking about. So sometimes I just tried to guess and answer to the best of my ability, and I don't think that was probably helpful to them. I've been called the wrong name throughout a suicide assessment, several times. And I've also had a therapist very much pressure me to state that I agreed to be safe when I was very much telling them that I was not. They asked, "Are you sure?" so many times that eventually I just agreed with them so that we could both get out of this very uncomfortable conversation. So during an assessment, an individual is already in a fight for life, for support. It shouldn't be this uphill battle. If you're an individual who's going in for a suicide assessment, sometimes you might see your long-term therapist you already have a little bit of a relationship with, or you may be meeting a stranger from mobile crisis. And they're asking you a lot of difficult questions that are hard to answer. At the same time, you are experiencing this internal struggle, this tug of war between two parts of you. There's the part that is working towards self-preservation, the part of you that wants to keep going, that wants to ask for help. Then there's the part of you that would be anywhere but where you were, the one that doesn't want help, the one that maybe is experiencing fear and anxiety because what does help look like? Where are they going to put me? Is that place going to be safer than where I'm at right now? You might be experiencing shame for asking for help because we're supposed to pick ourselves up by our bootstraps and be able to fix it ourselves. And at the same time, you're feeling shame for asking for help. You might also be feeling shame that you couldn't take that step and end your life. I remember being 14 years old and thinking, I'm a coward, I didn't just do it. And that's a real terrifying place to be. So this is why it is so important to think about these things as clinicians, to hold space for these really difficult feelings, to not be afraid of it, but to be able to hold space for it and come from a place of compassion. So as this talks about the power of connection and listening, joining with someone in their distress and listening deeply are critical steps in suicide prevention. I knew it was really important for me. Therapeutic connection built on empathetic listening can be life-saving. So we're going to demonstrate this now. We're going to go through a role play. And many of you have papers at your table. So I would invite you to view these scenarios. There's 2 different scenarios. We're going to go through one and then the other with a minute in between to take notes. Some of you have ones from the perspective of the client and some from the perspective of a clinician. So yeah, we're going to go through this now, take notes, and then we'll have a little bit of a discussion afterwards. All righty?
Okay. All right, be prepared for some incredible acting.
Yeah, totally.
So just for background, I'm a mobile crisis worker, and Ezri had called in earlier saying that they had thoughts of wanting to harm themselves and wanting to kill themselves. So I'm a mobile crisis worker going in to assess Ezri. Obviously, no, this is not to fidelity, but it's just kind of 2 different ways to approach this. So this is the first step here. Mm-hmm. Clap, clap. Hi, I'm Laura. I'm from County Crisis. Is it okay if I come in?
Yeah, sure.
Okay. I've been asked to perform a risk assessment with you. It's just a series of standard questions that we have to go through. Is that okay?
Yeah. It's kind of hard to talk about.
Yeah. No, I understand. It's just a required part of our protocol. These questions are going to help me to find the best way to help you and to determine what risk level that you're at right now. So if we'll just try to get through it together. I've heard you've been having some thoughts of wanting to end your life.
Yeah, sometimes, especially recently.
Okay. Sometimes. Okay. Can you quantify that? Like how often is sometimes? Is it daily? Is it weekly?
I don't know. Mostly when things get really bad. It's been really bad recently.
Right now? Okay.
Yeah.
And have you made any plans to act on these thoughts?
Not really. I thought about how I might do it, but I haven't specifically bought anything or I don't know. Okay. All right, so you have maybe a plan in mind, but no access to means if you thought about pills, you haven't been stockpiling them or anything? No. As I said, I haven't specifically done anything. Yeah. Okay, no, I understand that, but we do have to be specific here. I understand that they're hard questions. Do you have a timeline? Have you thought about when you might act on these thoughts? I don't know, and I kind of feel like I'm being interrogated right now. Oh, I'm really sorry. It's just an assessment. It's not an interrogation. I need this information so I can see the best way to help you, to see maybe if you need to go to the hospital or not. Are you currently feeling hopeless? Yeah. Okay. And do you believe that life is not worth living? Right now, Yeah.
Okay. And do you have a history of self-harm or previous suicide attempts?
Nope.
Okay. So I was gonna say that you don't seem that you're like high risk right now. I'm gonna recommend that you access counseling. Do you have a therapist?
I mean, I did maybe 2 years ago. I haven't been able to afford anything right now. I mean, I guess I could get in contact with them.
Okay. That sounds good. Can you just sign this paper here for me? What's their name? What's the counselor's name?
Wait, what are you gonna tell them?
Oh, this is just so that I have permission to like talk to the counselor. I just want to make sure that we can help you to get into counseling. But also know that, there's lots of resources that the county offers as well. There's like the 988, which you called earlier. Feel free to call that if things get worse, or if you feel like you are like having a plan that you want to like act on or anything like that. But also know that the county has tons of resources too. Would it be okay if I connect you with the county mental health and see about maybe going to some like day programs or something like that?
Yeah, sure.
Okay. End scene. I've always wanted to do that. I don't act. Ezri's the actor. So sorry. Okay, so that's scenario 1.
So please take 1 minute, write down any notes, anything you noticed, and then we'll start up in 1 minute.
Yeah. You want to just get started? Okay. All right, we're going to start the second scenario of this then. Clap, clap. Hi, I'm Laura Foster. I'm from County Crisis. Are you Ezri?
Yeah.
Okay, nice to meet you, Ezri. Before I come in, can I ask you real quick, do you have any dogs?
No.
No, okay.
I'm more of a cat person.
Okay, all right, thanks. Is this because sometimes like dogs may be like aggressive or something with people that they don't know, so it worries me for a little bit. Can I come in?
Yeah,
Okay.
sure.
Thanks. I heard that you've been having a bit of a hard time, so I'm here to see if I can help in any ways. Can I ask you what pronouns you use?
They, them.
Okay, thank you. Ezri, I use she, her. Is it okay if we sit down?
Yeah.
Okay. All right, thanks. So, Ezri, just like before we get started, I want to let you know that I'm a licensed counselor. So, anything that you share with me is going to be confidential. But if there's something that raises a concern around risk of like hurting yourself or hurting someone else, which just means we're going to have a conversation about what would be the best way to support you in that. And that may mean going to the hospital, but we'll talk about it and see the best ways that we can help you through that. But I'm here to listen and to try to understand what's going on. Also know that I don't have the best memory, so I'm going to be like writing stuff down. But you can absolutely look at what I'm writing. If you see me writing something that's incorrect, just let me know and we can change it. Is that okay?
Yeah.
Okay.
I think I've been kind of feeling like everything's falling apart.
Oh, I'm really sorry. That's going to be really hard. Tell me a little bit more about what's going on.
I feel like life is just kind of moving too fast, and I can't keep up with it anymore.
Yeah.
I work data entry, and my coworkers just, they just get done so much work, and they're all kind of meeting their quotas, and I never meet my quota. And sorry, it's hard to think right now.
It's okay.
I just keep feeling like I'm screwing up every day, and every day is the same, and I suck, and it'll never get better.
Yeah. I'm really sorry to hear that. Like, I can see how all of this weighing on you could feel like a lot. I can imagine it's overwhelming. Tell me what this feels like for you.
I think the word would be trapped.
Trapped.
I feel very trapped.
Yeah.
I feel like nothing I do is right,
Mm-hmm.
and I'm just always behind. I've been at my job for 6 years, and I think I've ruined every bit of trust with my boss that I could have had. And I don't even know who to ask for help. I don't think there's even anything I can do. I sit at my job and I wait for them to fire me.
Yeah.
And yeah, I just want to stop. I just want it to stop.
Yeah. Thanks for sharing, Ezri. So, you know that sometimes when people feel this way, they have thoughts about not wanting to live. You know that the reason that I came out here today was because it was reported that you were having thoughts about not wanting to live.
Yeah, I've been thinking about it a lot recently. It's hard to see any other way to stop feeling like I'm feeling.
Yeah. So, you know that this takes a lot of courage to do what you're doing right now, to be sharing about it. It's not easy, and thank you for doing that. Have you thought about how you would take your life?
I mean, I've thought about it.
Yeah.
I haven't specifically, like, bought anything or...
Yeah.
I'm kind of worried that no one would be here to take care of my cat.
Oh.
She's still pretty little.
Well, it sounds like your cat means a lot to you. I have 3 cats, and I love them, so I can understand a piece of that. What's your cat's name?
Dax. I put her away because sometimes she bites, but she's pretty adorable, though.
Yeah, I like that name, Dax. It's a cute name. I mean, Dax could be a very powerful reason for you to stick around. Are there any other reasons that are stopping you from taking your life?
Not really.
No, okay. Do you talk to anyone outside of work? I mean, not including Dax. Do you talk to anyone outside of work?
I'm always trying to get caught up with work,
Yeah.
so I don't really have time to go out and meet people.
Mm-hmm.
I haven't talked to my family in years,
Yeah, okay.
and since I moved here for work, I haven't made any friends.
Okay. Can you tell me a little bit more about the place about not wanting to live? Like, have you been thinking about, like, when you would maybe take your life?
I haven't made a decision or anything like that. It's more just like I have this feeling. I feel so heavy and like I could cry all the time.
Wow. Okay. I mean, I think I can understand that. I think that a lot of people in that situation would feel the same. You know, I don't think you're alone in that feeling of being overwhelmed. Maybe even a little bit hopeless. Have you ever felt this way before? Like, have you ever tried to take your life before?
Yeah, a couple times.
A couple times?
When I was a teenager, it was decades ago. So
Okay. And how old are you now?
I'm 40.
40, okay. Tell me about what happened when you were a teenager.
It was mostly because I was having a hard time in school. I have ADHD.
Yeah.
My parents didn't let me have the medications that the doctor prescribed. So I kind of just kept failing and failing. And teachers were making fun of me. Other students were making fun of me. My parents were making fun of me.
Oh.
And I couldn't handle a feeling like that anymore. I started self-harming, and twice I overdosed just with painkillers from the medicine cabinet.
Yeah. Okay. So, it sounds like when you were young that you were kind of going through a lot at that time. You're dealing with a lot of pain. And it seems like now you're going through a lot and dealing with a lot of pain. I see you have some meds out here. Do you mind telling me what medications you take?
These are just, this is a cough suppressant.
Okay.
I had bronchitis like a month ago.
Oh, gotcha.
I promise
gotcha,
I'm
okay.
not contagious. This is melatonin. I have trouble sleeping sometimes, and then sometimes it helps.
Yeah, okay.
And this is, I have Hashimoto's. I take levothyroxine. It's for my thyroid's just always off.
Yeah.
I think I've I'm finding it comforting. So I looked online, and if I ever feel like it gets too much, I know I can just take all of these.
Yeah. Do you have anyone that could hold your medications for you so they're not so tempting to take right now?
No, I mean, I don't have anybody. I don't.
Okay, that's fine. Ezri, I can see that you're hurting a lot right now. And like I said before, it does take a lot of courage to talk about these things. That you're here with me talking about this is a really good sign. This is a very positive thing that you're doing right now, Ezri. Not everyone can do this. I hope you can see that little piece of strength in you right now. And I want to help. I want to see if there's some things that we can do to help you out. Do you feel like you want to kill yourself right now? Let me rephrase this. Like, on a scale of 1 to 10, with 1 being like, I'm good, Laura, and 10 being like, as soon as you leave, I'm taking all these pills. Where are you at?
8.
Okay. 8's pretty high. It worries me. It does. I want to make sure that you're safe and that we can get you some help right now. The best way to do this is to go to the hospital and talk to a crisis worker there. This may mean that you stay there and go inpatient. It may mean that you go to a crisis residential program. Would you be okay to go do that with me?
Yeah.
Okay. And scene. Thank you for tolerating our acting.
Okay.
Ezri, you are up.
If you want to take another moment, take some notes, and then we'll have a brief discussion.
We're also enlisting Brianna to be the microphone person for the audience. And know that there's I don't know, Brianna.
It might just be on.
Is this on?
Yeah.
Brianna, really?
It's already on.
So, no, there's no right or wrong with this, right? There's not one way is perfect and one way is a mess. It's such a gray area, but it definitely encourage you to look at the questions here and share your thoughts and what did we miss? All the questions that are on there.
Okay, so we're going to start with scenario 1. We're going to start with the client perspective. So anyone who had this worksheet from the client perspective, how did Laura's words, tone, and body language make you feel in the first scenario? Right here? I'm scanning.
I think in the first scenario, at first I was kind of like, oh, okay, the tone's all right. But then I noticed the body language and like how she like distanced herself and didn't like show any respect for your home.
Yeah, that's what I was trying to do. So thank you for picking that up. For those who can hear, just like not really validating, I would say, not engaging in anything with as how Ezri was feeling. I was very clinical, like going through the assessment. If anyone's been in, an ER having to do crisis, sometimes it gets like this. And I'm not judging folks for being in that space. It's just sometimes there's lots of people to get through, and it can be hard. Yeah.
Yeah.
One of the statements that, as a clinician, that struck me was you said things like, you haven't been stockpiling medicines, have you? Like I would ever say yes to that, even if I was. So I thought that was a dead end.
Yeah. I really appreciate that, because I think like most of us that are clinicians, we kind of get this space a little bit, but I mean, you know how you go to like your PCP and like, whatever, you need this, that, and the other, and they ask you like they ask you like, are you feeling depressed? And I've definitely had nurses and, whomever doing that ask me and be like, you're doing okay, or like, you're not dealing with any thoughts of depression. I'm like, okay. I'm like, because they probably know I'm a counselor, but I'm like, I actually am really sad right now because my kids are in college and it's hard, so thank you for sharing that.
Yeah. I think that moves into, what were some things that maybe hurt the sense of safety and trust?
I was going to say that when you came in, you sat as far away as you possibly could, and it felt like you were going straight to business, like it was more of like filling a job description rather than actually caring for the person.
Yeah. I appreciate that too. Yeah,
and I think that's something that I think can be a common trap to fall into, especially, I can say as a new clinician, I can remember going into my first assessment feeling like I was a little bit nervous and feeling like I want to get this right because I did have the experiences I did, and I wanted to make sure I did right by that person. But sometimes that anxiety about this very serious situation can put a little bit of distance. And I know if I don't trust someone, that they have my best interests at heart, that they're in it with me, I'm not going to tell you if I've been stockpiling pills, or I'm not going to tell you, some of the things that I might if I feel like you do have my best interests at heart and that I can talk to you and you see me as a person. So that little bit of distance, that can make a big difference. Yeah.
Was I loud enough? I'm sorry.
I think I heard you, but can you just repeat into the microphone so everyone else could hear you?
I felt what you said, that you were feeling interrogated. So like you weren't given the chance to feel at ease to be able to answer tough questions like that. So she's coming in a like strict, far off manner and asking big questions. So.
Yeah, and there are a lot of questions that need to be asked, but it's really important to balance those questions with being human and having that relational piece. Because again, it's like, you feel like a science experiment when someone's just asking you all these questions. And people can tell, especially if they're, if the individual or client is somebody who's had multiple attempts and has been through this rodeo many times before, they can tell when you're reading off of a list. You can tell when like, oh, they're just trying to check these boxes for me. And that's something that might cause an individual to kind of close off and take a step back and not engage with that process. So,
I think there, and then there's in the back,
Right,
and then
okay.
here.
The language that you were using when you said, we just have to get through this, and I have to ask you these questions, and like it was very much just like going through those check boxes and asking those questions. I feel like that, to me, says, you know, I almost don't care what your answers even are. Like, let's just do it and get it over with. And that seems like something that really makes a difference and closed you off.
Can I want to speak to this for a second, because there's a space as like a clinician where when I first started in this work, and even in times now, like when you know someone is in a bad way, you know, first of all, I always think it's an honor if someone's going to tell me like the crap in their life, because you don't have to tell me anything, but that you can open up is awesome. And when I know this is probably going to be a 3 or 2, like this is probably going to be someone that's going to end up in the hospital. Can I convince them to whatever? This whole thing, it's a lot, you know. And I'll be very honest with you. When it's the end of the day and I got to pick my kids up, and I got to do all this other stuff, I'm like, sugar. That thought goes through my mind, and I have to check myself because I am paid to let go of that stuff. I am paid to say, you stop this here, and you take a breath and you let it go. But I think you could see that coming through, just being like, I just want to get this done. Yeah.
Last one for scenario 1, and then we'll move on in the interest of time. Go ahead.
Yeah, I could really relate to you, being that I have lived experience myself, and when I was in high school, I had a bad time. I was bullied a lot, and I didn't have any friends, and I had my first bad experience when I was a young adult, and I lived that way till I was 36. And now I'm healthy and I take care of myself, and I just became a certified peer specialist at the age of 63.
That's amazing.
Awesome.
So, and I have a job, and I love it.
Yeah.
Thank you.
And so there was a woman in the back that had her hand up before, the maroon cool button jacket thing
Okay.
back there. And then, I'm
Perfect.
sorry, move on.
I just wanted to say, I noticed the eye contact. You didn't make any eye contact with Ezri when you came in. So when you were asking questions, just the body language, you didn't pay attention to any of those body language cues at all.
Yeah, that's absolutely true. Yeah, there is kind of like, I think this thing with, especially when you first step into like getting help, where you're like, I'm gonna call someone and they're gonna help me. But when you call someone, they're there to assess you. When you go into the hospital, you're probably not talking to a therapist. You may be talking to like a peer support, maybe. You're probably talking to a nurse or a crisis worker that's doing an assessment to see what level of care you need next. You may be able to get meds, but it's not getting like, I think people think like, I'm gonna get help, it's gonna get better. It takes a hot minute to get to that space of actually getting into treatment and talking to someone that has this space. You know, there is a movement to kind of move away from that and to incorporate more peer support, which I believe is the key to all of this, is peer support specialists to kind of help people through these spaces. But it really is hard when you're going in because you think it's going to get better, and it usually doesn't from the start.
Sure. Okay.
I can speak loud.
Yell.
Sure, go ahead. Oh, wait, it's coming.
What I was going to say is, from the client approach, you put up a wall. The pillow is your wall. I don't know if anybody noticed that since you're talking about body language. Her pillow is her wall. Like her shield, I guess. Not a wall, but
Yeah.
more of a shield. And then well, I know we're not talking about the second scenario yet, but
Well, you can talk
in the
about it.
second
We're
one,
second scenario.
you took the shield down.
Yes, yeah. And yeah, thank you for also bringing it to the second scenario. I absolutely was using that as a shield. It is something I pretty much did every time when I was actually in those experiences. And I've seen other people do that. It's really hard, it's very vulnerable. And sometimes you want anything to protect yourself because you don't know what's gonna happen. So yeah, you have that kind of comfort object, and you can let it down a little bit when you feel like you're actually being supported. Thank you for noticing that. Anyone else, any other comments so scenario 2, what did you notice from the client perspective? What did you notice from a clinician perspective? Especially, I do want to hear, does anyone have any feedback as to would you have initiated 202 or 302?
I felt that right away. You tried connecting at the door, talking about the dog and that you're a cat person. And I think you were building a relationship before you got to the questions, and that was really important.
Yeah, thank you. I mean, I tried to like touch on some of the things that like some mobile crisis workers are, I haven't done mobile crisis, but no, just touches of it that, you're also like assessing safety for yourself when you're going into a house. So, you're want to see like, if there's anything here that's going to like hurt me. One thing that was missed in both is that I didn't ask about lethal means, if there was any guns in the house. But there are things that you should always be kind of in your repertoire with it, yeah.
Yeah.
Yeah, I said means, but it's really important to say guns. Like that's like the word you gotta throw out there.
I think the second time around, you moved you moved from the chair you were in originally and moved in closer.
Yeah, so that's actually an approach through CAMS. I've been very fortunate to actually work with Dr. Jobs. He's the founder of CAMS in a previous program. And one of his things is like you are working with the client together to solve a problem. It is not this old Freudian like psychoanalytical, like you're here and I'm looking at you. You're always going together with the person. So, and it makes a difference. It really does.
Yeah, again, it's that kind of feeling like a science experiment when someone's just kind of staring you down, as opposed to when someone's sitting alongside you and they feel more like an ally than kind of an adversary at times. Yeah, it makes a big difference.
One thing I really liked was you kind of asked for consent, and it felt like you were trying to like encourage like autonomy, like can I come sit down, can I come in, those type of things. Like I feel like provides an opportunity for them to feel like they're in control of the situation, less that you are, but more that the client is in control of how things are going.
You are so insightful.
Yeah. Yeah, that's very intentional because that is a big space where a client is feeling as out of control as they can be in that moment, and they're being very vulnerable and asking for help. So giving some control back to a client or an individual, it's crucial.
It's the tenet of a trauma-informed approach, right? Like choices, like you're not coming in bulldozing through things, it's just this or this. I don't know if anyone was just like verbal de-escalation, but the whole thing of verbal de-escalation is choices the whole time. You're never saying no to a client. You're always choosing it.
Okay.
Yeah.
I think this
The
might
other
have
thing
to
that
be our last question.
Okay, last question, or last comment.
Yeah.
Make it a
Happened
good
with the
one.
client in the second scenario is she gave you more information than you even asked her.
Yeah.
She went into depth because you started asking her about her emotions and feelings, which is part of your slide.
Yeah, I found that the conversations can get most of the information that you need for your assessment, but it takes time. It's hard to kind of like go through that practice.
I have a comment.
Oh, what, Brianna?
You also were affirming of pronouns, right? You asked Ezri their pronouns, and you made sure that they knew this was a welcoming space.
Yeah.
And then they opened up a lot more.
Right. It is important. It is important to try to find out who someone is and how they want to be called, because that's part of what our jobs are, is to be where the client is at. Thank you guys so much for sticking around. I know it's a long day. I really appreciate it. If anyone has any CEU questions, you can come see me. But have a good rest of your day. Thank you.